Hello and good evening, everyone, and thank you for joining us this evening. And a very warm welcome to our 8th webinar in our brand new practitioner series. Today's topic is all about bone health. My name is Ella, and I'm the practitioner lead here at DR.VEGAN. And we also have with us today our guest Dr. Katie Hodgkinson, who's a GP with a specialist interest in women's health. Now, before we start, I really wanted to quickly mention that our practitioner webinars are intended only for professionals. So these include trainee nutritionists, nutritional therapy practitioners, dietitians, naturopaths and pharmacists, and they're not intended for members of the public. Okay, so I want to give you a very brief introduction to myself and Katie. So I have a passion for practitioner education and have previously worked in a lecturing and clinical supervisor role at one of the major nutritional training institutes. And I've since put my passion for education into training practitioners at DR.VEGAN and creating materials to make clinics much more easier and efficient. We're thrilled to welcome with us today Dr. Katie Hodgkinson. As I mentioned, is a women's health and lifestyle specialist. So Katie, do you want to tell us a little bit more about yourself?
Yeah, so hi, thanks for having me on this. Hi, I'm Dr. Katie. I'm a GP, private GP at Spire in Southampton, and also lifestyle medicine doctor. And my clinic, Hampshire Health and Hormones, I do mostly online consultations, some face-to-face, but it's mostly managing hormone health. It's a sort of functional way of managing hormone health, but I do also prescribe HRT if it's indicated, but spend a lot of time talking about diet and lifestyle supplements if they're indicated. I see a lot of perimenopausal, menopausal women, but also things like PMS, PCOS, endometriosis, and also men as well for lifestyle consultations, although probably the majority are menopausal women that come see me.
Okay, fantastic. And I'm sure you're going to learn a lot of interesting things from you today, Katie. So we're really happy to have you on here. Now, before we start, I did want to add, just please do feel free to ask questions as we go along. We will be having a question and answer session at the end where we'll be answering your questions. And there might be time to only go through a few questions at the end. So if yours doesn't get answered, or if there's a question you don't feel comfortable asking here, then please do reach out to myself and I will be able to help you. And I'll be sharing my email address and Katie's email address at the end. So without further ado, let's get started. Okay, so today we're going to be covering a wide range of topics relating to bone health. So that includes bone health statistics, factors influencing bone density and bone strength, the hormone decline, osteoblasts and osteoclasts, bone architecture, a look at how the hormone decline after menopause and how it affects osteoclasts and osteoblasts, a discussion of HRT and bisphosphonates, looking at DEXA scans as well. What does it mean if a client comes in, gives you a number from their DEXA scan, how to interpret that and how to understand that a bit better. We're going to look at what we can do from a lifestyle perspective, and also we're going to give you an introduction to our new supplement Osteo Friend. And then at the end, we're going to have a discussion and questions. Okay, so to start, I want to give you a few statistics. Some are quite shocking. So 3.8 million people are estimated to have osteoporosis in the UK. And this was taken from 2025, this figure, I believe, so it's quite recent. And among those over the age of 50, 1 in 2 women and 1 in 5 men will suffer a fragility fracture in their lifetime. So that's a significant amount of people. You know, half the female population will have some degree of fracture due to poor bone health. Sorry, that's that side there. Okay, so 26% of hip fracture patients die within 12 months, and there is a 6.5% mortality rate within 30 days. So again, that's a really significant statistic. And hopefully these statistics are going to inspire you to help clients with bone health and starting bone health early and kind of looking into that. So osteoporosis is also called the silent disease, and that's because most people don't know they have it until it's actually too late. And of course, there's rising recognition, which is fantastic, especially among women in their role of diet and bone health. And women are taking steps to protect their bones earlier. And actually, as nutrition practitioners, we really need to be educating people on the importance of, building strong bones, even starting in childhood, making sure that children are getting the right nutrients to calcify their bones effectively. And of course, up until the age of 30, you're kind of building those bones. So it's really, really important to make sure that, people are aware that they need to, make sure they're having the right minerals and they're doing the right exercises and having that right lifestyle that's going to protect their bones later in life. And of course, osteoporosis is incredibly life-limiting, and it can be life-threatening, and it costs NHS over £4.5 billion annually, which is obviously pretty staggering. Okay, so let's have a look at factors influencing bone density. Okay, so I briefly touched on, insufficient nutrients during the bone building years. That can be one factor. So when you are seeing children, thinking about their future bone health, is their gut working properly? Are they getting the right nutrients in there to start building that bone to protect them in later life? So you need to have, plenty of bone building nutrients, and I'll go through all the nutrients later on, but I suppose the main ones are calcium, magnesium, vitamin D, and protein to help protect the collagen within the bones, and we are going to talk about that in much more detail. So kind of by the age of 30, that kind of peak bone mass, and then after that you kind of start to maintain bone density until the menopause, and then you lose it at a significant rate, which we will again discuss later. But you've got those the first 25 to 30 years of your life, which are really, really important for building those bones, setting the stage for the future. Okay, a lack of weight-bearing exercise reduces mechanical stimulation on bone, which is crucial for maintaining bone formulation. So again, making sure our clients are leading a healthy lifestyle. Are they going out and getting those weight-bearing exercises on a regular basis? Diets high in sugar also contributes. Excess sugar can promote calcium loss and inflammation. Or excessive caffeine can also interfere with calcium absorption and increase urinary calcium excretion. So these are all things that then cause the body to leach calcium and takes it away from the bones. Chronic stress elevates cortisol levels, which can negatively impact bone formation and calcium balance. Again, making sure our clients are kind of in that rest and relax state for 12 hours a day, and getting proper resting and having proper stress relieving techniques as well. And again, heavy metal toxicity is also a problem, so particularly from lead or cadmium. So that can impair bone metabolism and replace calcium in bone tissue. So again, looking at the metal load of our clients, if that's relevant for them. Okay, let's have a look at factors influencing bone strength. So we've got collagen, so that's really, really important, and I'll discuss that in a little bit more detail later on. But collagen needs proper enzymatic cross-linking for its strength. Advanced glycation end products and poor glucose control stiffen collagen and contribute towards making bones brittle. And then we've got the bone microarchitecture as well. So the internal structure called the trabecular cortical arrangement, which impacts the strength. So even with adequate bone mass, poor connectivity or thinning of this part of the bone can reduce resilience. Okay, we've also got micro damage accumulation as well. So repeated small stresses from physical activity or aging can also create micro cracks. And if this repair isn't sufficient, then bones can become brittle over time. And we've got inflammation as well and oxidative stress. So chronic inflammation and oxidative stress damages bone cells, so both osteoclasts and osteoblasts, and that leads to weaker bone matrix independent of bone density. So even if somebody has got a good bone density, we still need to be looking at, protecting bones in terms of reducing inflammation and reducing oxidative stress on the body to help protect those bones as the person ages. And then we've got the vascular blood supply as well. So adequate blood supply ensures nutrition, oxygen, and waste removal as well. And poor vascularization can also impair bone health independent of bone mass. And again, you know, when we're looking at blood flow, we're looking at are they exercising regularly to help stimulate the blood flow? Are their arteries clear to allow efficient blood flow? To all the blood vessels, capillaries, so making sure that kind of their cardiovascular system is healthy as well, because that was also relevant to the nutrient supply for bones. Okay, so here is a nice visual of how estrogen declines as we age. And as you can see, so by the age of 80, actually you're going to be having very little protection for your bones from estrogen. And again, Katie's going to discuss it a little bit later on. But this is a nice image you can show to your clients so they can understand kind of estrogen decline a little bit better. Okay, so let's have a look at osteoclasts. Okay, so they're derived from the hematopoietic stem cells of the monocyte macrophage lineage, and they're multinucleated giant cells, and they're responsible for bone resorption. Okay, so they secrete hydrogen ions via hydrogen positive ATPase pumps, which acidifies reabsorption and dissolves the high hydroxyapatite. They release cathepsin K matrix metalloproteinase, which degrades collagen and the organic matrix. They're activated by receptor activator of nuclear factor kappa B ligand, and which is expressed on osteoblasts and stromal cells. And they're inhibited by osteoprogerin, so a decoy receptor secreted by osteoblasts. Okay, they're stimulated by parathyroid hormone, hydroxyvitamin D, and inflammatory cytokines as well, so interleukin-1, TNF alpha, etc., etc. And they're suppressed by estrogen, and this is one of the ways that we can explain, you know, post-menopause increase and reabsorption. Okay, so let's have a look at osteoblasts. So they are derived from the mesenchymal stem cells, and they're bone-forming cells that synthesize organic bone matrix. So that's the osteoid type 1 collagen and non-collagenous proteins, and they also regulate mineralization. So they secrete osteocalcin, alkalized phosphatase, osteopoietin, and bone sialoprotein. Okay, and that promotes mineralization by increasing local phosphate and reducing pyrophosphate. They're stimulated by bone morphogenic proteins and suppressed by sclerostin, which is produced by osteocytes, and glucocorticoids. After bone formation, osteoblasts either become osteocytes embedded in bone, or they become the bone lining cells. Okay, so here you can see the progression of osteopenia to osteoporosis and the mineral loss that can occur from bone. So kind of on the right side, we've got severe osteoporosis, that's kind of end stage. And then on the left-hand side here, we have normal bone, or what a normal healthy bone should look like. Then we've got osteopenia, which I feel like isn't talked about much, but that's kind of the step in between normal bone and osteoporosis. So you've got some bone loss, but not quite to the extent of full osteoporosis. Okay, so Katie, I've got a few questions for you. So Katie, firstly, how does the hormone decline after menopause affect osteoclasts and osteoblasts? Do you want to describe that for me in detail?
Sure. So we talk about the hormone decline. So in the perimenopause, well, first thing that happens is progesterone gradually declines. Then you get a fluctuation of estrogen and it overall declines. And then there's minimal production of those hormones at menopause. Testosterone is also a really important hormone in women as well as men, but it declines from about the 30s onwards. Not every woman that reaches menopause will have low testosterone, but it's not uncommon. And those hormones, also known as the sex hormones, so estrogen, progesterone, testosterone, can have an impact on our bone health. So I'm just going to run through those. So in particular, estrogen has the most impact, progesterone to a degree, and testosterone also, but it is in particular it's estrogen that's the main one. So estrogen basically inhibits osteoclast formation and activity, so it reduces bone resorption. It promotes osteoblast activity and survival, so it basically helps with supporting the bone formation, and it helps decrease inflammatory cytokines, which basically help stimulate osteoclast. So basically it's helping with bone strength. When you've got a decline in estrogen, you've got an increase in osteoclast activity, so increased bone resorption, and the lifespan of osteoblasts decreases. So basically you've got reduced production of the bone matrix proteins as well. And for example, type 1 collagen. Also what can happen is you can have reduced growth factor activity, which stimulates bone formation. So basically bone formation is not keeping up with bone breakdown. That can lead into reduced bone mass and architecture. So the strength of the bone reduces, and then that can lead to osteoporosis risk, osteoporosis and increased fracture risk. So it has a huge impact on our bone health. Progesterone, much smaller amount because it doesn't have so much of effect. It basically promotes osteoblast activity, but it doesn't really have much effect on the osteoclasts. Testosterone can have an effect on both. Basically, it helps promote proliferation of osteoblasts, but indirectly and directly can inhibit osteoclasts. So indirectly, because testosterone converts to estrogen. So those hormones can have a huge impact on our bone health, and it can have a huge impact on our risk of osteoporosis. In particular, if you go through an early menopause, so basically premature menopause before the age of 40 or early menopause before the age of 45, then your risk of osteoporosis hugely increases. So, a lot of the time if osteoporosis is diagnosed at those ages and you've had an early menopause, it's often down to that, particularly the reduced estrogen that's occurred at that time.
Okay, wonderful. That's really interesting, actually, Katie, to know about all those different hormones and kind of how they affect the osteoblasts and osteoclasts. So I guess really then that brings us on to our next question. If I can try and change the slides here, that'd be helpful. There we go. So what about HRT then? Can you give us a talk through that? Like, is it safe? How does it protect the bone? What are the risks and what are the benefits? So when would you recommend it? When wouldn't you? When wouldn't you recommend it?
Okay, so HRT has been around for many years, about 60 years. It's kind of changed a bit in terms of what we tend to prescribe. So more commonly prescribed is body identical HRT, which is identical to the hormones naturally produced in the body. So derived from yams or soy, made in a lab. Also prescribed sometimes is the synthetic progestin, slightly structurally different to the progesterone we naturally produce in the body. And there's a slight difference with that between how somebody responds to it and the risk to do with that. So is it safe? So generally HRT is considered safe in most cases and effective for managing symptoms of menopause, but it also has secondary benefits like helping with bone protection, helping with reducing cardiovascular risk if someone's before the age of 60, and can help with cognitive health as well. So as I said, in most cases it's safe and effective, but it does need to be a case-by-case basis. So, you want to give a person an informed choice, talk about the risks, talk about the benefits, making sure there aren't any reasons they can't have it. There are very few reasons why you can't have HRT, but for example, a hormone receptor positive cancer, you shouldn't have HRT. But even women who've had breast cancer, if they're not hormone receptor positive, then what I would do in those cases, if someone is having menopausal symptoms, I would always discuss with their oncologist or breast surgeon and discuss with them. If they have a non-hormonal receptor positive breast cancer, then it may be that they can take HRT. In terms of other risk factors, so clotting risk, if they have estrogen orally, there's a slight increased clotting risk. If you have estrogen on the skin, so as a patch, a gel or a spray, it bypasses the liver, which activates the clotting pathway. And so it minimises the risk of clotting. The difference between a progestin and body identical progesterone, there is a slight increased clotting with progestin. So there's a slight difference there. So even someone that's had, DVT, for example, doesn't mean they can't have HRT, but you absolutely wouldn't want to give an oral estrogen. Womb cancer risk, if you have estrogen, you must always take progestin or a body identical progesterone for womb protection. If you don't, then estrogen can build up and increase the lining of the womb, which can lead to endometrial hyperplasia, and that can lead to womb cancer. So the progestin or progesterone is licensed for womb protection. And basically that brings down your risk of womb cancer back down to what it would have been had you not been taking the HRT. So breast cancer is another biggie. So a lot of women either came off HRT or didn't start it. Generally a sort of generation ago, really, because there are a lot of headline news about HRT and breast cancer risk. We now know actually it's low risk. And then we think about other risk factors, lifestyle risk factors, which are often higher. 2 or more units of alcohol every day, smoking. One of the big risk factors for breast cancer is being overweight. So body mass index of 30 more than doubles the risk of breast cancer. Even being overweight can increase the risk. Being inactive can increase the risk. So, it's really important just to put that into context. But, important to examine the breast, have regular mammograms. So, you discuss all these factors with a patient to then make an educated decision about whether or not to start it. And if we're talking about bone protection, then, we know, and British Menopause Society talks about how, HRT is a really useful way of helping to reduce osteoporosis risk. Basically, it's reversing some of the postmenopausal changes in bone remodeling. So it can help, with the osteoblasts, help reduce the osteoclast, help with bone mineral density, help with bone matrix proteins, help with the responsiveness to growth factors. So HRT can be really, really helpful. But there are certain times when you would consider actually prescribing it as a treatment for osteoporosis. So, for example, premature menopause, it's first-line treatment for osteoporosis. If someone is before the age of 60 and they've got menopausal symptoms, then it can be useful to help with bone protection anyway. But also if they've gone through an early menopause, then for osteoporosis treatment, where it's not advised, if someone is over the age of 60, as a kind of first line treatment for osteoporosis, or if they simply don't have any menopausal symptoms and you're only thinking about giving it for bone protection, then British Menopause Society suggests actually you ought to be thinking about other things like lifestyle modifications, calcium, vitamin D, diet, lifestyle, etc., and then assessing somebody's risk for osteoporosis. So there are certain guidelines about when you would or wouldn't prescribe it for the purpose of osteoporosis.
Perfect. And I just have one more question actually on this, if you don't mind, Katie. So how long would women typically be on HRT for? Is it kind of like 10 years, or would it be longer in some cases if they have osteoporosis? Would they be on that like indefinitely, or like what's the general time frame for that?
So if someone goes through an early menopause and they're using it for osteoporosis, it's normally advised they stay on it for at least until the average age of menopause, so 50, 51. Bearing in mind that if they come off it, then some of those benefits of the HRT can be reduced, or they will be reduced eventually. And it might be that certainly if they've got osteoporosis, they need to think about an alternative medication for it. Typically, how long should you be on HRT for? That has changed. We used to give a set timeline. We used to take people off it, women off at age 60 or after 5 years. The 5 years was because of perceived significant increased breast cancer risk. And at 60 was because of increased heart disease risk. But at that point, most people were taking most women taking oral estrogen, and that, as I said, does increase, that can increase your clotting risk. Whereas if you take estrogen on the skin, then there isn't a timeline per se for that. However, you need to assess someone at least every year. if they're on HRT, to assess reasons whether it's still okay to continue on it, if there's any reason to stop it. So it's not like you kind of leave someone on repeat prescriptions forever. You do need to have regular assessments.
Okay, perfect. And when you take HRT through the skin, is it in the form of a patch or a cream or?
Yeah, so patch, a gel or a spray. So the spray that is called Lenzetto. The patches, there are different forms. Some are bigger and smaller than others. And then the gel, there are 2 different types. So estrogel is commonly prescribed. It's a pump dispenser, or there's also another one which is not prescribed so often. So, you know, what I tend to prescribe generally, women who are in the perimenopause tend to favour the gel because you can change the dose very easily as hormones change. With the menopause, I mean, many women like the patch because you change it every 3.5 days and it stays on there. You've got to remember to change it. But I guess with the patch you can cut bits off or add patches, but it's harder to change the dose, particularly if your hormones are fluctuating. So it is kind of nicer, I guess, to have the gel, which is an everyday gel you apply to the inner thigh, just for that variability in case things change. And you can also give low doses if someone needs only a low dose of estrogen.
Perfect, fabulous. Okay, so what about bisphosphonates then, Katie? What can you tell me about those?
So yeah, first line treatment, unless you're early menopause, for osteoporosis is something called bisphosphonates, and they're usually pretty effective when someone's got established osteoporosis to reduce the hip and spine fracture risk. And they work on the osteoclast, so they inhibit the activity of osteoclast. And what that does, it allows the osteoblast to work more effectively. It can be used for other reasons as well as osteoporosis. So, for example, Paget's disease, or if someone has bony metastases from cancer. Most commonly used is oral bisphosphonates, but you can give it IV as well. In particular, if you want high doses, or, you know, for example, we've got metastases, you might give it IV. Now, orally, you tend to give it at least, or advise to give it for at least 5 years, IV at least 3 years. Some people need longer if they're having fractures on treatment, if they're older, if they've been on long-term steroid usage. So you tend to need to give it more than that. The most commonly prescribed sort is nitrogen containing. So alendronate and risedronate are commonly prescribed for first line treatment. Basically what it does, it inhibits an enzyme which is needed for osteoclast formation. And as I mentioned, commonly prescribed is oral. You can take it daily, but most people prefer to take a kind of a set dose weekly because you can get gastric side effects like reflux, abdominal pain. And those effects are minimized by, and this is why people prefer to take it weekly. They often, so they are advised to stand up for 30 to 60 minutes after they take it. Take it with a large glass of water, not with food and drink or any supplements or medications, particularly not calcium supplements at the same time. Calcium supplements can inhibit absorption, and they need to stand up 30 to 60 minutes, and that's weekly. So yeah, they need to do it on an empty stomach. So in terms of side effects, you can get side effects. Obviously, the gastric side effects are minimized by standing up. It can reduce calcium. So for that reason, it's advised to take with calcium, and often calcium and vitamin D, like Adcal D3, Calci or other supplements to help with the calcium. It also can give side effects. For example, this is very rare, but jaw necrosis. So basically you kind of have a breakdown of the jaw. Also rarely atypical femoral fractures. And then particularly if women, been taking it 5 years or more, but it's rare, it's not common. It's important to think about kidney function as well. You would do a baseline kidney function blood test. If it's EGFR, glomerular filtration rate is less than 35, then you wouldn't start it. But normally if kidney function is stable, you might just check it annually unless it's dropping. So it's important to factor in that. The other thing to think about is even after you've stopped using it, it can stay in the bone for years afterwards. And it's important to go and see your dentist, keep up to date with your dental reviews, to only go before you start taking it, and regular dental monitoring, obviously the impact on firstly of osteoporosis on our teeth, but also calcium as well. The other thing is thinking about a drug holiday every now and then. After about every 3 to 5 years, recommended to have a little break from it if you're low risk. Obviously, if you're high risk, then maybe not, but you wouldn't necessarily take it all the time. You might have a little break and then reassess. So you might want to get, say, a DEXA scan and just check things.
Okay, perfect. And I suppose the same question in regards to this one as well. Kind of how long, what's the typical duration of people taking this medication?
Yeah, so at least 5 years for oral, at least 3 years for IV, and then I guess you'd assess it. And as I mentioned, some people need it for longer if they've got ongoing risk factors, like they're having steroids or older, or they've had recent fractures on treatment. So you'd assess it on a case-by-case basis. Or if they have side effects, obviously you might switch to something else. So
yeah, of course. Okay, perfect. Okay, so do you want to talk about DEXA scans as well? How you might interpret them,
okay.
when they occur.
And if I do that, perhaps before I go on to DEXA, if I talk about FRAX.
Yes, actually, that'd be great to talk about.
Because that kind of lends into it. So NICE guidelines. Basically, you want to think about assessing fracture risk in certain groups of people. And in particular, women over 65, men over 75, if they've got low body mass index, if they've had early menopause, for example, they've got previous fragility fractures, if they've had kind of low trauma, low impact fractures, long-term steroid use, those sorts of patients, you want to think about doing a score called what commonly used as a FRAX score. There's also a key fracture score, but basically what that does, it's assessing your risk of a fracture at 10 years, so fragility fracture. And you put in lots of kind of data into there. So you're putting in things like age, weight, whether someone drinks alcohol, smoking risk. So in particular, 3 or more units of alcohol daily will increase your risk if they've had a previous fragility fracture, any steroid use. So in particular, thinking about, so prednisolone steroid, if you've had 5 milligrams or more for more than 3 months, that can increase your risk. Things like rheumatoid arthritis, hyperthyroidism, those sorts of things. Then you put those numbers into a scoring system, and then that basically is looking at, you get 2 numbers. One is looking at your major osteoporosis fracture risk, and then also hip fracture risk as well. And essentially hip, shoulder, spine, etc. will be like a major osteoporosis fracture risk. So you get a score, and essentially it comes up as low, intermediate, or high risk of osteoporosis. If it's low risk, so if the major osteoporosis fracture risk is less than 10% risk over 10 years, or hip is less than 1 to 2, then it's low risk. And you give lifestyle advice, diet advice. You maybe consider adding like calcium D3. So thinking about minimizing the risk. Obviously, you're talking about query HRT if someone's menopausal. Moderate risk, so if the overall major fracture risk is 10 to 20%, and hip fracture risk 2 to 5%, you would then go on to be advised to do a DEXA scan. If it's high risk, so the major fracture risk is greater than 20, or the hip fracture risk is more than 5, then you would go, that would lend yourself to going on to having treatment plan, thinking about that treatment plan for osteoporosis. So you would do that first of all. However, there are certain criteria, certain people where you might actually think, actually, I want to go on to do a DEXA scan anyway. Basically what it is, it's looking at bone mineral density. So it's looking at your hip and your lumbar spine, so lower spine. And it gives you a score. So basically that score is comparing to normal average person population at a young age, so between 20 and 30. It's comparing that with that cohort. And it gives you a score. So essentially osteopenia, so that kind of in-between stage, is a score of -1 to -2.5. And -2.5 and lower would be classified as osteoporosis. And there's certain criteria of people where you would consider doing a DEXA scan. So obviously, if you've got the FRAX score and it's coming up as moderate or high risk, then you would do it. And then other risk factors. So, for example, if someone's had a fragility fracture or low trauma fracture, if they've gone through an early menopause, if they've had ovaries removed, if they've gone through amenorrhea, so no period for perhaps 9 to 12 months or so, if they've got malabsorption, so maybe things like celiac disease, chronic renal or liver disease. The reason for that is with renal disease, it can affect your calcium and phosphate balance and vitamin D activation. And that can affect bone metabolism, and that can lead to something called secondary hyperparathyroidism, and that can lead to high bone turnover. So that can lead to osteoporosis risk. Liver disease can impact on various things like low bone formation, low body mass index, so particularly sort of less than 20. Smoking, we know that smoking can bring on an earlier menopause. It can impact on hormones, which can impact on obviously that can impact on bone health. It can also affect on the osteoblast, osteoclast. So smoking is not good. High alcohol intake, as I mentioned. So yeah, 3 or more units. Long-term steroid use. If someone's on aromatase inhibitors, for example, if they've got breast cancer and they're on particular medication called aromatase inhibitors, then you would want to think about doing a DEXA scan. And in terms of how often you do it, so typically it's around about every 3 years. Family history as well. I guess if someone's got a strong family history of osteoporosis, then you want to consider that as well. So yeah, so how to interpret it, just look at the scan report. It will tell you if it's classified as osteopenia, osteoporosis. You might just have osteoporosis in one area, like a hip or spine or both, and it can vary. So yeah, it depends what the score shows in terms of guiding you what to do. With osteopenia, obviously you want to think about lifestyle factors, calcium, vitamin D, diet, lifestyle, etc. Osteoporosis, first line, as I mentioned, is bisphosphonates. If that's not tolerated or someone can't have it, then you might think about other forms of medication. So, for example, is something called denosumab. Basically, that works in a similar way in terms of it's affecting reducing osteoclast activity. And it's an injection every 6 months. The problem with that is if you stop it, then you can get quite rapid reduced bone density. And it's important to have some kind of temporary therapy in between. I guess if that was the case, I probably want to just discuss it with, say, a rheumatologist for their advice on that one. I mean, normally, to be honest, someone that's getting injections would be rheumatology managed anyway. So it might be that rheumatology is just managing all of it. Also, if that's not tolerated, or another option is something called raloxifene. So it's under the SERM family, SERM, so selective estrogen receptor modulator. So basically what that does, it's kind of like it mimics estrogen. It sits in estrogen receptor sites, and that can be useful for women who are postmenopausal. If someone can't tolerate other medications, one thing to consider though is that it can increase clotting risk. So you want to assess their risk for deep vein thrombosis, etc., pulmonary embolus before they start it. And it may reduce breast cancer risk. It may have some benefits there with helping with that.
Okay, wow, I'm certainly learning a lot on this webinar. Okay, so Katie, is there anything we can do then from a diet and lifestyle perspective? Anything else? What would you recommend, really?
So I think you're going to cover the diet, aren't you, in a second?
Yeah, I'm going to cover diet in a second. Yeah. So okay. Obviously, lifestyle things that can go, lifestyle interventions you can put alongside medication, but also if people don't want to take medication, like what would you be recommending?
Yeah, that's right. Not everyone wants to take bisphosphonates or HRT, or they can't take it or whatever. But diet and lifestyle is really, really important, not only preventative, but also if someone's got osteoporosis, you want to kind of reduce the risks. So Exercise really important. So weight bearing aerobic exercise, basically the mechanical stress on the bone can increase osteoblast activity. So, you know, things like I don't know, dancing or walking or something that's going to put weight affected. Really important to do muscle strengthening exercises. Basically the muscle contractions pull on the bone, and that can promote bone strength and mass. Not only that, it can help with coordination and balance. Thinking about other coordination and balance activities, so things like yoga or Tai Chi, really good. Obviously, you want to reduce your risk of falls, because if you are someone with reduced bone mass and you have a fall, obviously that really puts you at risk of having a fracture, and then, you know, that can be risky for many reasons. Smoking, I talked about already, but avoiding smoking, reduces your estrogen, can have a toxic effect on osteoblasts, it can impair your calcium, and it can, in some people, women, have an earlier menopause, not hugely, but maybe like 2 or 3 years. Limiting your alcohol intake, that can also impact on osteoblast and osteoclast formation. It can reduce hormones, those sex hormones. It can reduce mineral absorption, which we need for bones. It can impair calcium absorption, and also, not only that, it's a falls risk of falls if you're having alcohol. Sunlight exposure, really important. Obviously, vitamin D. Sunshine converts vitamin D into its active form, and we need that vitamin D to help calcium, which we need for our bones. It's not to say you've got to forget about sun cream. Obviously, sun cream is really important, but getting a burst of sunshine, obviously in the winter months, then you're not going to get as much, you're not going to get as much sunshine, but it's not as effective in terms of that impact on vitamin D absorption. Not as effective in converting into its active form. So supplementation, which I think you're going to cover, is important as well for vitamin D. Making sure your weight's healthy. So low BMI is a risk factor for osteoporosis. Obviously, you don't want to be overweight. That can create stress on your joints. It can be inflammatory, which can start other processes. So normal BMI is important. Important to have a medication review. So we talked about long-term steroid use. So making sure that actually you're on the right dose, and, you know, obviously with steroids you need to reduce it slowly, but also, if you're on long-term steroid use, just being aware that actually it's an increased risk for osteoporosis, and do you need a DEXA scan to check that out. PPIs, so proton pump inhibitors, commonly prescribed to things like omeprazole, lansoprazole for heartburn, gastritis. They can have side effects like reducing mineral absorption, so things like B12 and magnesium can be reduced, which we need for our bones, and also they may interfere with osteoclasts. So PPIs, worth looking into that if you need it or not. And then finally, just thinking about things to reduce your falls risk. So get your eyes checked, go to the optician regularly, have good footwear, and making sure you have aids to help you walking if you need. So avoid things around the house which can be a trip hazard. So it's thinking about those things, so you're reducing your falls risk. So those lifestyle measures can potentially help.
Perfect. Thank you very much for that, Katie. I'm going to have a look now at what we can do from a diet and nutrition perspective to obviously recommend our clients alongside some of those lifestyle interventions. Okay, we're going to have a look at what the studies actually say, because there's a lot of advice out there, but sometimes it's not always backed up by research. Okay, so let's have a look at protein. So a study in the Journal of Clinical Nutrition concluded that a 25-gram increment of dietary protein intake was associated with 14% lower risk of hip fractures in underweight subjects. So I guess really, if you have somebody that is underweight, looking at what is a sensible protein intake going to be for those people. And even if somebody is a normal weight or even overweight, you need to be working out that their protein requirements appropriately. We do actually have on our DR.VEGAN's professional website a protein calculator. So you can put in all of your life stages, how heavy you are, what kind of physical activity you do, and it will calculate the optimum level of protein that you need per day. And although it's great to get protein from the diet, a variety of different protein sources, sometimes it is helpful to add in an additional protein supplement, so a protein powder, just to increase those levels if they're needed. Sometimes they can be quite hard to get enough protein through the diet to kind of match the need, especially if you're an athlete or particularly active. So looking at those levels, and again, if you are underweight, kind of looking at getting more protein into the client, and obviously full body nourishment as well. That's really important to look at. Okay, so now we come to a low sugar diet. Now, as nutrition professionals, I'm sure everybody recommends that nobody is eating, that their clients aren't eating kind of loads of sugar or high sugar diet, but it's really, really more especially important for people that are worried about their bone health, that have osteopenia, osteoporosis, or just want to kind of decrease their risk of fractures, to make sure they're having a low sugar and a low GL diet. So a study in the Journal of Molecular Medicine concluded that an excess of sugar causes inflammation, hyperinsulinemia, increased renal load, and increased urinary excretion. So as you can see here on the right hand side, so sugar triggers an increased calcium excretion, lower calcium absorption and transport into the intestines, and it also leads to an increased osteoclastic activity, lower osteoblastic activity, and also lower vitamin D activation. So as well as being inflammatory, increases your calcium loss through the urine and decreases vitamin D activation, as well as all the other problems that you can have with a high sugar diet or high GL diet, things like insulin resistance, all contributes to kind of that picture of poor health that we see. So really, really important, get your clients on low GL, no added sugars, no refined carbohydrates, none of the white poison. Just get them to make those healthy swaps. If they want something sweet, give them some apple and cinnamon tea, and these kind of low sugar healthy foods that you can recommend. So that's really, really important there. And I suppose in the same time, also looking at their blood sugar balance, because if you've got spikes and dips, that's also probably going to lead to calcium excretion. So make sure that they are having those the protein and the fats with the complex carbohydrates as well. So you're kind of keeping those levels stable rather than having those peaks and those dips. Okay. So let's have a look at homocysteine. Okay. So here's a study from the New England Journal of Medicine. So the study concluded that an increased homocysteine level appears to be a strong independent risk factor for osteoporotic fractures in men and women. So I guess really because when you have high homocysteine, you have high inflammatory markers, which kind of contribute to this poor bone health picture that we see. So one of the ways that you want to protect bone health and cardiovascular health is to be looking at homocysteine, get their levels checked. If it's high, make sure they're having, the right B vitamins to bring those down, and that you're supporting that whole methylation process to kind of keep those levels down, not just for the bones, but also for overall health. High homocysteine levels is a risk factor for many, many things. Most people think it's just for cardiovascular. But also for a lot of other diseases, including bone health. So that needs to be one of the tools in your toolbox that you think about when your client comes in, concerned about their bones. Maybe they've already got osteopenia, osteoporosis. Get the homocysteine tested and deal with it if it's high, because that's really important. Okay, so foods rich in calcium, like obviously we need to have the right vitamins and minerals in the diet. I couldn't do one of these pages for all of the nutrients needed for bones, but here's kind of like just a base that you can show your clients. Do feel free to take a picture of it if you needed, or you can screenshot it from on-demand viewing later on. So here's kind of the plant-based sources of calcium. And of course, if your client does eat meat or animal sources, I've put the animal sources at the bottom as well for reference. But even on a plant-based diet, you know, make sure they are consuming, making an effort to consume enough calcium per day to help support their bones. Okay. Okay, and the same here for magnesium-rich foods. So magnesium-rich foods tend to be much higher in plant-based foods. So with plant-based diets, you do generally tend to have a lower calcium intake and a higher magnesium intake than omnivores. So if you are, you know, if your client is on a plant-based diet, do kind of really focus on getting that calcium in there. And, you know, if they're eating a healthy plant-based diet, the magnesium should come in naturally anyway. But if you are dealing with omnivores, people that eat plant foods and animal products, then you need to also be focusing on how to get magnesium rich foods in there, because magnesium is found to be slightly low on people that do eat animal products. So make sure, you know, they're getting their pumpkin seeds in there, their nuts, green leafy vegetables, for their magnesium. Okay, and here we have vitamin D3 and vitamin K2. Now, plant-based diets, really your vitamin D is kind of linked to mushrooms, fortified foods, and of course, supplementation and sunlight. That's really, really important. Again, if your client isn't plant-based, then there's other sources of vitamin D, such as fish, butter and eggs, but really the vitamin D in there is actually very low. So even if they are consuming animal products, I would still look at testing their levels, get them a supplement, make sure they're going out every day, getting sun exposure, and making sure that their levels are high enough. I wouldn't just rely on vitamin D rich foods, even if they are, you know, consuming them in high amounts. Still really important to test, because, you know, vitamin D is found in really low levels, even in those foods, animal foods that I've mentioned. And of course, with the vitamin K2, so you've got in there, that's from natto, which is fermented soybeans. And then you've got other forms of fermented vegetables like sauerkraut, kimchi, and other kind of fermented soy products. So these are really good sources to make sure that are being consumed every day. But also your body can convert K2 from vitamin K1, which is found in green leafy vegetables, dark greens, you know, your chards and things. But conversion is limited, and conversion also is reliant on having a healthy gut microbiome. So you know, that's something that you also need to look at. That's really, really important. And we're going to cover that in a minute, actually. Okay, so collagen. Okay, now we have you might be wondering why I have a picture of a brick wall here, but it's kind of an analogy. So collagen is so important to bones because it's like the cement in the brick wall. So you can imagine that when you're looking at bone health, like you've got your minerals, calcium, magnesium, phosphorus. These are like the bricks in a brick wall. Whereas the collagen comes in, and the collagen is what keeps those bricks together and cemented and keeps that wall strong. So if you build a wall without cement or adequate cement, just one knock and that wall is going to fall or going to crumble over. If you have adequate cement, then that wall is going to be much stronger. And regardless of size, you can have a massive wall but no cement, and it's going to knock down a lot easier than a small wall with adequate cement. So it's really important to make sure that your client has adequate collagen levels. And of course, to build adequate collagen, you need to get the correct amino acids in there. You need to get in things like vitamin C, lysine. We're going to be discussing a little bit more when we talk about the ingredients of osteopren a little bit later, those nutrients for collagen. And we do actually have a slide here which looks at the nutrients that are needed for collagen production. So again, as I mentioned, vitamin C, it acts as the cofactor for propionyl lysyl hydroxylase enzymes, which is essential for stabilizing collagen fibers And as Katie mentioned earlier, you know, smoking increases your risk of osteoporosis and osteopenia. And one of the things that smoking does is decreases your vitamin C levels within the body, and therefore decreases the strength and the function of collagen. So really important to make sure that vitamin C levels are high enough. And if your client does smoke and they don't want to give up, or they can't give up, you need to give them additional vitamin C. So it's about 25 milligrams per cigarette. You need to give them extra. Okay, so we've also got lysine and proline as well. So these are the amino acids required for collagen formation in the triple helix structure. Copper as well. So that serves as a cofactor for lysooxidase, which helps to cross-link collagen fibers and increase strength. We're also looking at zinc as well. So zinc regulates collagen gene expression and aids in tissue repair and regeneration. And then we've got iron, again, which supports hydroxylation of protein and lysine necessary for collagen maturation. So this is something you can request from the GP to have a look at their iron levels, or there's some private tests available as well. But this would be one of the things I'd be looking at along with their vitamin D levels. And then silica as well. So silica stimulates collagen synthesis and enhances connective tissue integrity. And omega-3. So omega-3 helps to reduce inflammation and protect collagen from enzymatic and oxidative degradation. And then, of course, you've got the antioxidants in there. So they help to neutralize free radicals and prevent collagen breakdown from oxidative stress. So it's really, really important that we do look after their collagen. And, you know, many people take collagen supplements, but it's kind of a heavily debated topic, because at the end of the day, any protein, including collagen, is going to get broken down into its individual amino acids and then reused in the body where it's needed. So there's some argument that if you take collagen, that's just an expensive protein supplement, and you'd be better off just increasing the amount of protein that you're having in your day-to-day diet. Okay, so we're going to have a look at other issues now, which you want to watch out for and help to correct in your clients that are worried about their bone health. Okay, so the first one we're going to look at is gut function, and that is really essential for proper nutrition and absorption and regulation of inflammation within the body. And of course, poor gut function is associated with an increased risk of osteoporosis. And a study actually published in the Journal of Medical Principles and Practices concluded that there was an increase in osteoporotic fractures in women with IBS. So again, you know, gut is the seat of health, and it's one of the first things we should look at when we have clients in our clinic. Okay, so another study found that 68% of newly diagnosed celiacs had bone mineral density changes. So again, if your client comes to you with celiac disease, it's been newly diagnosed, or even if they had celiac disease that wasn't diagnosed for a long time, that is a red flag in terms of future poor bone health. So you really need to be kind of looking at healing that gut, making sure that nutrient absorption is optimal to protect those bones in the future. Okay, and another study here is looking at the link between IBD and osteoporosis again. So unfortunately, if you have IBD, you do have an increased risk of osteoporosis. So again, with irritable bowel diseases, looking at kind of reducing the overall inflammation in the gut, but as well as the whole body, looking at repopulating the gut, making sure that there's the correct level and the right type of microbiome going on in the gut. So, you know, take time to do your stool sample analysis, look at the bacteria in the gut, and kind of work on that gut health. Okay, so you also want to be reducing inflammation. So an increased level of diet-related inflammation leads to lower bone mineral density. So again, make sure your clients are consuming a rainbow of foods every single day. I tell all my clients, make sure you eat the rainbow. Get those antioxidants, anti-inflammatory foods in there. You know, stop eating trans fats, stop eating sugars, artificial chemicals or anything like that. Just, kind of really give them that anti-inflammatory diet. Okay, and here's a really interesting study about autoantibodies. It's really important to get autoantibodies under control. So the study here showed that bone loss was triggered by autoimmune-related inflammation. The network of inflammatory cytokines produce chronic inflammation, which induces uncoupling of bone formation and reabsorption, resulting in significant bone loss within autoimmune diseases. So again, making sure that you are targeting the gut, and then you're looking at the gut-associated lymphoid tissue, what microbiome is in there, and are you regulating those T cells? That's really, really important. Just reducing those autoantibodies. And again, that's a whole, autoimmune diseases is a whole nother subject, or we could spend 4 or 5 sessions on, but that is something that you do need to look at in your clients. Okay, so now I want to introduce you to our new product, OsteoFriend. It is a fully comprehensive formula with 19 ingredients that target 7 pathways that are typically impaired with those of poor bone health. So it is a flavourless powder, and it is super easy to take. So rather than having to take 6 or 10 capsules per day, you just take 1 heaped teaspoon per day. And that is kind of a barrier, like taking so many tablets and capsules is a barrier to people taking their bone supporting supplements. So some of you might be aware, nutrients like calcium and magnesium are really bulky, and they're actually quite difficult to fit into capsules. Hence, some bottles and brands recommend 6 or 10 capsules per day, which leads to poor compliance. But when you have a product like this and a powder, it's actually just 1 heaped teaspoon mixed into water. It doesn't taste of anything. Tried it myself, doesn't taste of anything, and you just knock it back, and that's your supplementation done for the day. Okay, so we're going to have some of these ingredients. You can see all the ingredients are down there on the side, and it is the most comprehensive product on the market. Okay, so let's have a look at vitamin D. So vitamin D regulates calcium and phosphate homeostasis by increasing intestinal absorption of calcium and promoting bone mineralization. It also enhances osteoblast differentiation and reduces parathyroid hormone levels, which in excess can lead to bone resorption. And then we've got calcium. So as the main mineral component of bone, calcium forms the crystalline structure of hydroxyapatite, and adequate intake is essential for to maintain bone mineral mass and strength. And insufficient calcium levels can trigger parathyroid hormone release, promoting bone reabsorption to maintain serum calcium levels. So there's a good dose of calcium in this product. Magnesium, again, another essential mineral that works in balance with calcium. Magnesium supports bone structure and acts as a cofactor in vitamin D metabolism. So it helps to regulate osteoblast and osteoclast activity and contributes to the structural development of bone through its role in bone matrix formation. Clinical research has shown that magnesium supplementation can alleviate the symptoms of osteoporosis to some extent. So it's not the miracle nutrient, but it does help. And when used with other nutritional therapeutics, other diet and lifestyle guidance, magnesium is definitely going to be one to help with bones. Okay, so we've also got some lysine in there as well. So lysine aids in the collagen cross-linking, which is a key process in the bone matrix stability. It also enhances calcium absorption in the intestines and may reduce urinary calcium excretion, thereby supporting skeletal calcium retention. So not only does it help with cross-linking, it helps to increase the absorption and reduce calcium excretion. So it works in multiple ways, actually, to support bone health. And lysine isn't one that people generally think of when they're thinking about bone health, but it is so important. Okay, so we've got boron in here as well. So boron modulates bone metabolism by influencing the activity of hormones such as vitamin D, estrogen, and testosterone. It also reduces inflammatory markers, which may support bone remineralization and calcium retention. So we've got silica in here as well. So silica contributes towards synthesis and is involved in the initiation of bone mineralization. It's particularly important in the early stages of bone formation and may improve bone density by enhancing calcium incorporation. Selenium. Okay, so through selenium proteins like glutathione peroxidase, it protects osteoblasts from oxidative damage. So deficiency is associated with a reduced bone mineral density and increased osteoblast activity due to elevated inflammation and oxidative stress. And zinc is also essential for osteoblast proliferation, collagen synthesis. It also supports alkaline phosphatase activity, which is necessary for bone mineralization, and modulates the effect of vitamin D on bone cells. Okay, so we've got a manganese. So manganese acts as a cofactor for enzymes involved in the synthesis of proteoglycans and glycosamygdalins. Sorry, can't say that properly. Glycosamygdaloglycans, which are important for components of the bone matrix. It also supports antioxidant defenses and may protect bone tissue. We've also got copper in here, which is required for the activity of a lyso-oxidase, an enzyme essential for cross-linking collagen and elastin, which contributes to bone matrix strength. It also plays a role in antioxidant enzymes protecting bone tissue from oxidative stress. Okay, vitamin C. So as mentioned earlier, is so important for collagen synthesis and also acting as a cofactor for propionyl hydroxylase. Promotes osteoblast differentiation and has antioxidant properties that protect bone forming cells. Okay, we've also included in the formula MSM, which helps to provide bioavailable sulfur needed for collagen production and connective tissue integrity, and it may also reduce inflammatory cytokines that contribute towards osteoblast activation and bone resorption. And of course, we've got essential vitamin K2 in here, because what bone product would be complete without vitamin K2? So vitamin K2 activates osteoclast and matrix GLA protein, which combines the calcium and incorporate it into the bone matrix, reducing the risk of arterial calcification, promoting proper skeletal mineralization. So that is one of the concerns when you have higher intake of calcium is arterial calcification, but by taking K2, that helps to reduce that risk. And we have in here also curcumin, which inhibits NF-kappa B, reducing osteoclastogenesis and bone reabsorption. It also has a potent anti-inflammatory and antioxidant effects, potentially preserving bone mass in chronic inflammatory states. Now, Lactobacillus reuteri is one that we don't see in bone health supplements very often, but it is one of those things that is proven to help with bone density. It modulates the gut microbiome and the immune system to reduce systemic inflammation and promotes bone formation. It enhances calcium absorption and may reduce osteoclast activity through Treg mediated pathways. And we've got piperine in there as well, so that enhances the bioavailability of calcium by inhibiting hepatic and intestinal glucuronidation. It also has mild bone protective effects through its anti-inflammatory mechanisms. And finally, we've got the B vitamins, so vitamin B6, folate, and B12, and these are in the active methylated form, so pyridoxal 5-phosphate, methylfolate, and methylcobalamin. And they work synergistically to regulate homocysteine metabolism, which of course is essential for bone integrity. And elevated homocysteine, again, is associated with impaired collagen cross-linking, reduced bone quality, increased fracture risk as well. So vitamin D supports collagen formation and neurotransmitter synthesis, while folate and vitamin B12 also essential for DNA synthesis, methylation, and bone marrow function. Deficiencies in any of these B vitamins can disrupt osteoblast activity. It can also compromise bone matrix quality and also increase the risk of osteoporosis. So you need to be getting those homocysteine levels down. Okay, so here are all the references that we used today. So do have a look of those. If you do want them emailed to you, do let me know. I can drop them over in an email. Quite a lot there. Okay, so now we're going to be going on to a quick question answer session. So let's just have a look to see what's come in. Okay, so we've got a question here. Bridget says, I thought biochemically one shouldn't take calcium and magnesium at the same time. I think if you're taking mega doses of each for a certain reason, then you want to be taking them separately. But taking them in a formula kind of together increases compliance, and also they do work together as well. So as mentioned earlier, you know, they are both needed for the bones, and then the magnesium supports the vitamin D, which then supports calcium absorption. So it does really help with compliance for your clients to take them together. And of course, a supplement taken is better than a supplement not taken. Okay. And then we've got one as well. Remind us how much vitamin C per cigarette. So it's 25 milligrams per cigarette is lost. So that's what you want to be replacing on top of what you would normally give somebody for health benefits. Obviously, you know, people can take too much vitamin C and can give them diarrhea. So just watch out on that. But hopefully your clients aren't going to be smoking a pack a day, or you'd hope not. But just kind of encourage them to decrease their smoking if they can't stop completely, as well as, of course, increasing their vitamin C. Okay, we've got another question here. Where does the metal load come from? Is it the environment or what we ingest? It can be from a variety of factors. So it can be environmental exposure. So smoking can increase your heavy metal toxicity levels. Certain medications contain heavy metals as well. So some contain aluminium. So it's kind of like, you know, pesticide exposure. These kind of add to your metal load. So it's kind of looking at your lifestyle and helping people to make clean choices. So stop the smoking, you know, eating organic food, and just being really careful. Like hopefully nobody's got lead pipes anymore, lead paint. But you might have an older person that grew up with lead paint or lead pipes. So just look at that. And of course, you can always do a heavy metal test if you're unsure. Okay, so are there any other supplements you'd recommend alongside OsteoFriend? I would say supplements such as omega-3 are really important. So our vegan omega-3 helps to reduce inflammation. Also gut works as well. So if somebody's got a poor gut, make sure they're looking at re-inoculating, kind of improving dysbiosis. And also if they're you know, perimenopausal or menopausal, we've got a perimenoFriend and perimenoFriend and menofriend supplements as well. So kind of just play it by ear, kind of whatever your client needs. But we have got quite a range of supplements that would go with OsteoFriend. And of course, if they do need more protein, we have our new protein, creatine and superfood blend as well to support joints and muscles. And of course, when you support the muscles, you can help to prevent falls, which then helps with osteoporosis, risk reduction or fracture risk reduction. Okay, so that actually comes to the end of our questions. I hope I've answered everything. So my email is on here. If you do have any more questions, do drop me over an email. And Katie's email address is on there as well. And you can also have a look at her website, which is healthandhormones.co.uk. So do pay Katie's website a visit. And so thanks for your questions, everyone. And there will be a recording of this webinar going out. So for those of you that couldn't join us today, you know, this is on demand, or if you want to watch again, make sure you do watch it on demand. And anybody that was watching live tonight can try a free OsteoFriend product, so you can try it for yourselves, or give it to somebody you know that's got osteoporosis. And again, our supplements can also be purchased from the natural dispensary, so sometimes that's easier for clients just to send, just to go there for all of their supplement needs. And again, I just wanted to remind everyone that you are all invited to sign up to the DR.VEGAN practitioner scheme, so you can unlock a load of benefits, commission on sales, clinical news, and free monthly products as well, and practitioner only perks. And so I want to say also a big thank you for Dr. Katie Hodgkinson, who's been fantastic tonight. And don't forget to sign up to our webinar next month, which is on men's health. So details of that will be available in the next few weeks on email. So thank you, everyone. I really hope that you found today useful, and enjoy your evening, everyone.
Thank you. Thanks for having me.
No worries, Katie.